Hi, this is Dave Ashkin. I'm the medical director of the SNTC, or the Southeastern National Tuberculosis Center. I am so thrilled to be with you guys today. Obviously, I wish I was up there with you. I wish I would have the opportunity to be there. But what we're going to do today is something I think kind of exciting, which is that we're going to go over an interesting case, and then we're going to go over some background. And then at the end of this, what I'm hoping to do is be able to have a discussion with you live using the phone or the computer lines to really discuss some not only questions that you may have about this case, but also other questions or issues you have with tuberculosis. So with that, first of all, I really would like to thank Dr. Itger and her staff for allowing me to speak at your event today. This is the World TB event, and it's such an honor for me to be able to share this day with you. You know, one of the things, as you can see from the lecture here, is that I'm going to call it surprise. It's TB, and really it's surprise. It's World TB Day. But the idea, the reason I call it surprise it's TB, is because I don't know about you, but I can't tell you how many times, how many consults we get where we suddenly are speaking to the doctor and they tell us, you know what, I was so surprised. It turned out to be TB. It wasn't what we expected. Or I don't know about you, but again, being in the field of tuberculosis, you'll talk to your friends, your family, and you tell them what you do, and they're like, I thought TB was gone. I am really surprised. And while that's great that TB is going away, and people may not realize the impact it's having, it is having an impact on the way we do TB. And I'm hoping by going over a case like that we're going to discuss today, we can go over some of those issues that are occurring and see how we can improve it. So first, what I'd like to do is to talk about World TB Day. And as you know, World TB Day is recognized each year on March 24th. It commemorates the date that in 1882, Robert Koch, who's really the father of microbiology, went and announced his discovery of Mycobacterium tuberculosis. And he announced that shocked the world that this bacillus, this organism, actually was killing the disease that at the time was killing 1 out of every 3 individuals. And he made that announcement, and from there on, the control of TB really picked up. And because of the efforts that came and the enthusiasm and the the ability to really finally recognize what caused the disease and now really try to figure out how to attack it, how to kill it, TB became where we are today, where in the United States we've been able to somewhat control it. We're doing an okay job in the world, as we'll talk about. But the bottom line is we still have a lot to do. And that's what World TB Day is all about. It provides an opportunity to raise awareness about TB and what measures are needed to tackle this devastating disease. You know, it was interesting when Robert Koch first announced his discovery, he started off the discussion with this statement, which, I mean, just really to me anchors what he was about to talk about and really emphasizes the significance of his discovery. He said, if the importance of a disease for mankind is measured by the number of fatalities it causes, then TB must be considered much more important than the most feared infectious diseases, plague, cholera, and the like. If one only considers the productive middle-aged groups, TB carries away 1/3 and often more of these. And, 1/3, 1 out of every 3 individuals in Europe, in the United States from the 17 to 1800s were estimated to be dying of TB. Put that in perspective for a second, 1/3. If you take all the people right now who are dying of cardiac disease and cancer, 2 leading causes of death right now in the United States, if you combine them, the 2 of them don't kill 1 out of every 3 individuals. That's why TB was known as the White Plague, because it pretty much was affecting everybody, and it was considered to be the good plague. The Black Plague, the bubonic plague, would come, go into a town, wipe it out, and it was gone. But the White Plague was essentially what we were supposed to die from. And I know it sounds weird, but if you think about it, while we're unbelievably upset when somebody we know or love dies of heart disease or cancer, while we're obviously devastated, that's what we die of. Back then, what you died of was tuberculosis, and that's why his discovery was so important. And what was really important is now we finally had an enemy. We had this bacillus, and that made a lot of people now suddenly start to figure out, how do we kill this bacillus, especially at a time in the 1930s and 40s, when the concept of antibiotics was becoming prevalent, that people started to finally realize that you can actually use substances to kill these bacteria. And as you know, some of the earliest antibiotics was penicillin, but some of the earliest ones along with penicillin were the anti-tuberculosis therapy, like streptomycin. And H. Corwin Hinshaw, who's one of the physicians at the Mayo Clinic, who actually first tested streptomycin and won a Nobel Prize for medicine for it, when he accepted the Nobel Prize, this is what he said. At the midpoint of the 20th century, TB was recognized by all of us as the white plague, undeniably the most dreaded enemy of the human race by any measure. Whether measured by prevalence, cost, social consequences, sheer misery, or any yardstick, I believe that any observer at the time would consider the bacillus of TB as the enemy #1 of the human race. None of us, myself included, believed its control could be attained by medical means within this 20th century. He believed, a lot of people, the medical community believed, that we could control TB with antibiotics, that we could eradicate TB with antibiotics. And why was that? Because after these antibiotics, streptomycin, INH, rifampin, after they were discovered and implemented, we saw TB going down by 5 to 7% per year. It looked like by the year 2010, the CDC came out and said by the year 2010, TB would be eradicated. And we know that didn't happen, because in the 1980s and 1990s, soon after they made those predictions, what happened? TB came back. And even today, as you know, it's estimated TB is still killing more individuals in the world than it ever did before. So the bottom line is we still have this battle, and we're still waging it in order to try to conquer it. So we have to acknowledge something that I think is important. I don't know about you, but I sit through a lot of lectures, and during a lot of lectures, people will get up and they'll say, you'll hear about diseases, and they'll say, if we only knew what caused this disease, we could control it. Or if we only had good ways to diagnose it, we can control it. Or if we had treatments or cures, we can control it. But that's the ironic part. With tuberculosis, it should be the envy of all other diseases. For the last 130 years, we've known the etiology of tuberculosis. We've had very good tools to diagnose TB. Not only do we have therapies, we actually have cures. And not only are the cures available, they're relatively cheap. And yet, as you're aware, still about 1.8 million people, that's over 4,500 deaths. That's unfortunately like 10 747s every day going into the ocean. 4,500, 1.8 million people a year are dying of TB worldwide. It is still the top infectious killer worldwide, but yet nobody knows about it, And that's what World TB Day is really about. World TB Day is to really raise the awareness of tuberculosis. The bottom line is, I don't know about you, but it's not uncommon for me when I am going around, talking to doctors, talking to lay people, that they're surprised TB is still there. And that's what World TB is about. The World TB Day is about trying to educate. It's our opportunity to make people more aware of TB, which will help us with our diagnosis, our treatment, and make sure we have the resources we need to continue to battle. The World Health Organization on the left here, they have this poster, and their theme this year, as well as the CDC's, is Wanted Leaders for a TB-Free World. And what they mean by that is they need leaders in the community. They need leaders in politics. They need leaders in medicine, in our medical community, and they need leaders within our lay community to know about tuberculosis and to commit to once and for all making sure that we eradicate tuberculosis. But I have to say to you, we've been doing this. We're going to continue to do it, but people are still surprised. And what I'd like to do, if it's okay with you, is I'd like to go over a case where, quote unquote, the doctor's involved, and not for any, for very, understandable reasons, were surprised. So the case is a 7-year-old U.S.-born Spanish-speaking female. She had no prior medical history whatsoever. She presented to a hospital in Florida with a 1-day history of progressive right lower quadrant abdominal pain. She denied any fevers. She wasn't vomiting. She had no constipation. She had no diarrhea. Her last bowel movement was 3 p.m. the prior day. They went ahead and they did an abdominal exam, and sure enough, she had some mild right lower quadrant tennis. There was no rebound, meaning there was no peritoneal signs, but she had an elevated white cell count. And because of that, the ER doctors were very, very concerned that she may be having a peritonitis, something that we all definitely see. So they went ahead and they did a CT of the abdomen, and the CT of the abdomen, sure enough, showed dilated and fluid-filled appendix with a 7-millimeter coliff with a periappendiceal inflammatory changes that were consistent with acute appendicitis, and there was no evidence of any perforation. But what surprised them was this. When they looked at the CAT scan, they also showed that both of her ovaries were not only enlarged, but they were calcified. And they also noted, as I'll show you, what looked like a pleural-based atelectasis of scarring. Concerned that this may be appendicitis, they started her on antibiotics. And this is, as you can see here, this was the CAT scan of her abdomen. And I know for many of you, it's a little hard to we're not used to looking at MRI, CAT scans, but what you can see here is this structure right here is actually the appendix, and it's really enlarged. And you can see in the middle of it, it's filled with fluid. When you look at other views, this from the side, you can see it again. There's actually a little air in there, again, that they're worried about this being, inflamed. And here is actually the little stone that was actually blocking the appendix, the appendicolith. And what you can see also here on the CAT scan is that her ovaries here, and you can see it really well here, were really enlarged. They were very, very big here and here. And as you can see, they actually had calcium in it. This really shocked them. They weren't expecting this. This is the little pleural-based lesion they saw here, very small. Here it is in the right middle lobe. Here it is in the right lower lobe, just like plate-like atelectasis. So what happened was, they thought she had an appendicitis. They went ahead and they wanted to do a laparoscopic appendectomy. They wanted to use the scope to go in there and remove the appendix. But interestingly enough, when the surgeons went in there to try to take the appendix out, they noticed that the omentum was pretty much stuck to the front part of her abdominal wall, so much so that they couldn't get the scope in. They tried to dissect it, and no matter what they did, it was adhered. And the adherence seemed, the adhesions, I should say, were going all the way down to the patient's pelvis. And because of this, they had to go in there and they had to do an open procedure, what we call a laparotomy. And when they went in there, they did the appendectomy. They took her appendix out, but sure enough, both of her ovaries, when they went to take a look, were both enlarged, and they had what looked like masses on them, what they thought were inclusion cysts. And again, there was just a lot of adhesions all over that was sticking the organs to the abdominal wall, but they were able to dissect them out. So the intraoperative findings included dilated and erythematous distal appendix with localized adhesions, diffuse adhesions from the omentum to the abdominal wall. Both of her ovaries they thought had inclusion cysts. They were able to dissect them off. The good news is that they were able to keep her ovaries there. They would just cut off the quote-unquote cysts. And also when they were in there, as we'll talk about, they looked at her ileum, and it didn't have any adhesions or inflammation. And they sent the specimens, and here's the key, in formalin, including the appendix, the ovaries, and the omentum, to pathology. So they weren't thinking TB, and I'm not saying they should have, but they weren't thinking TB, so they didn't send the right specimens for culture. And for all of us in TB, we know where this is going. So the bottom line is that the patient had an uneventful postoperative course, which is great. But interestingly enough, when they looked at the pathology, the appendix looked like an acute appendicitis. There was periappendicitis and she also had pinworms. Subsequently, as we'll talk about, we did go and take a look at the appendix, and there was really no signs of granulation or necrotizing granulomas in the appendix. But interestingly enough, when they looked at the bilateral ovaries, they found that she had multiple areas of necrotizing granulomas with occasional multinucleated giant cells. And when they stained it with a phyte stain, which is a modified AFB that they use on tissue, now they sure enough saw positive staining bacilli, which is consistent with mycobacterium. The omentum just showed fibroadipose tissue with chronic inflammation. So I don't have to tell you, but you know where this is going. When the pathologist saw this, he was surprised. And, given that the pathologist saw this, he suggested this may be an infectious cause, and they went ahead and they got an infectious disease consult. And the infectious disease consult requested that, a number of studies and asked more questions. And the first thing she asked was the child healthy? And the mother says, child had no symptoms before this. This was all acute. She was a little bit of a picky eater, she said, but really was fine. She never coughed, never had fevers. Last antibiotics, as we'll show you in a little while, was a year ago for an otitis media, but nothing else. She got better. And there was nobody, according to the family, that had TB or was anywhere. This is a child who was born in the United States, had never gone to Mexico or anywhere else, even though her family was from Mexico. Her father was a migrant worker. He traveled the United States, but was otherwise healthy. And the mother and the little girl had a sister. They all were fine. Nobody was sick. There was also an aunt and an uncle who was from Mexico originally. They visited the family, but nobody was sick. And like I said, no travel to Mexico, no travel outside the United States. There was no family visits from relatives from Mexico. And, the infectious disease, consultant was really, really, interested and kept going and said, what about eating any unpasteurized cheese or milk or meat? And they denied it, and the child didn't have a history of BCG. They went ahead and they did an HIV test and brucella, which is part of the differential diagnosis. They were both negative. And they went ahead and did a PPD and a quantiferon. This is the chest x-ray that was done after the procedure. And what you can see here is what we kind of saw in the CAT scan, a little streaking, and this is the middle lobe, a little atelectasis, nothing really major, nothing that screamed tuberculosis. The patient was discharged home. She was in good condition, and she went home 2 days after her procedure, and she had a follow-up with a pediatrician and her infectious disease consultant. 2 days after she left, she was seen by the pediatrician. They read her PPD as positive. And unfortunately, I don't have what exactly the millimeters were. I think all of you there always get a little uptight about when we hear positive. We always like to hear the exact millimeters, but it was quote-unquote positive. But interestingly enough, also her quantiferon was positive. As you can see, the antigen minus nil was 9, and as you guys know, anything more than 0.35 is considered positive. So this is highly positive. And her mitogen, meaning a sign of her immune system, was very, very strong. It was 8.66, anything more than 0.5. So this was a strong positive, As part of the workup, they also, and we'll talk in a little while, but one of the things also about, quantiferons, and PPDs, even, with kids, and she was 7, it can be used. They also did a CA-125 and noticed that was elevated. And just kind of an aside, especially in adults who we see this kind of disease, the CA-125 is, normally a marker that we use for ovarian cancer, but it can definitely be elevated in patients who have TB peritonitis or abdominal TB. Her ESR and CRP, or C-reactive protein, were normal. And again, when they went and asked her again, because everything is positive, she absolutely denied any history of tuberculosis or TB symptoms. So here's what I'm going to ask you, and I got to be honest with you, it's very hard. This is a recording, so I'm going to just talk to myself. It's my usual schizophrenic self. So I'm going to just ask my voices in my head, and let's see what it says. But what now? I think we've all been in this situation. What do you do now? You have a young girl. She had this, what we thought was an appendicitis. Lo and behold, surprise, she has caseating granulomas. The AFB smears are positive, but we have no cultures. And we have no cultures because we weren't thinking TB. It was a surprise. And then also, we now have positive PPD and quantiferon, which goes along with she has been exposed, it seems, more than likely to TB. But how'd she get it? There's no risk factors, What's going on? So my question, I guess, is to everybody, how do you confirm the diagnosis? And I want to talk to you about, the issue and where we could do and what we could do today. I think you'd agree, If this was 15 years ago, the answer is we couldn't confirm the diagnosis. We'd just have to go and treat them clinically. But now with PCR, polymerase chain reaction, we have that ability. And as you know, you can do PCR off of tissue that was put in paraffin or even off of paraffin blocks. You know, again, the organism does not have to be alive in order to make the diagnosis, because all you need for PCR is the presence of DNA. So interestingly enough, in this case, the hospital sent the specimen to an outside lab which did PCR, but interestingly enough, the PCR was negative for TB as well as non-tuberculous mycobacterium, and they did it twice. They were so like, this got to be TB. So now I guess what I would ask you is, what would you do now? You know, do you just start the kid on meds, you know, or do you try to pursue the diagnosis more, or both, you know? And that's kind of where, you know, where I came in. What happened was the patient was seen by an infectious disease consultant as an outpatient 2 weeks after the procedure. And interestingly enough, the patient was in the 45th percentile for height, so she was a little short, but 61 percentile for weight, and her BMI was 68%. I mean, she really wasn't that malnourished, you know, going along with the mom saying she was asymptomatic. So what happened at this point is that the ID and the pathologist didn't, you know, they were really perplexed by this case, and that's when they called me. And Florida's kind of an interesting place. We actually have 67 counties, and actually all of our counties are under one program. So even though these counties function separate TB programs, when it comes to the overall administration, it's all under the umbrella of one program, including we also have one medical director, which is me, who reviews all the cases. And I do consultations not only for the SNTC, but for the state. And what happened was, when they discussed the case with me, you know, my feeling was that this was probably, you know, genital urinary TB, but we didn't know the source. And I strongly recommended that the family be referred to the health department so that we could try to find where this may have came from. I also asked them to ask the family again about any sick family members, neighbors, visitors. And I also went back and said, again, we really need to try to ask about, did they have any unpasteurized milk or meat? You know, and I suggested, you know, do sputums for AFB just in case, you know. And then what I think was the most important thing was to send the pathology specimen to the CDC pathology lab, which we'll talk about in a minute. And I felt strongly that, you know, in the meantime, given everything, the child needed to be started on 4 drugs. But the problem is that we really did need to confirm the diagnosis, and you're going to say why. But, you know, to me, as we'll talk about in a little while, when I see TB potentially of the appendix or the ileum, and it's now spreading to the pelvis in a young child who has connections to Mexico, as we'll talk about, the probability or possibility of M. bovis comes up. And we'll talk about why that's important and how it changes our treatment, and why we would like to know that if we could. So we sent the specimen to the CDC pathology lab, and as we also talked about, we went ahead and we started the child on 4 drugs, given the pathologic findings and the positive LTBI tests, or, you know, positive PPD and IGRA, which support the diagnosis of this being TB. But remember, even though the PPD and the IGRA are positive and it supports the diagnosis of TB, let me tell you that M. bovis or M. tuberculosis will both have a positive PPD and quantiferin. It's the BCG strain, or the strain that was developed from bovis to become a vaccine, that will give you a negative quantiferin, but the bovis will still give you a positive. So it really didn't help us. So I just want to show you, you know, I don't know how many of you have ever used the CDC pathology program. I highly recommend them. They are amazing. So we sent the specimen to the CDC. It usually has to be done through the state as a consult. And as you can see, they found the same thing, that the entire ovary was extensively replaced by well-formed granulomas with multifocal regions of necrosis and abundant multinucleated giant cells of foreign body and Langerhans types, meaning these were macrophages that all fused together to cause these multinucleated giant cells. It's something that we see in TB, and you can see it in other, but really usually in chronic granulomatous diseases. They also saw within several macrophages and multinucleated giant cells that they found debris and some evidence of consecrations, but they didn't see any fungal organisms. But here's the beautiful part, as you can see, they do all this. So they did when they looked at the Zeal-Nelson, which is one of the ways they can look for AFB, it was negative. When they looked at the GMS looking for fungus, it was negative, but the Phyte stain again was positive. And then what I'd like to show you, which is a real advantage that the CDC does, not only do they do PCR, but they also do immunohistochemical staining, which is they actually have antibodies that look for mycobacterium in the tissue. And that, as you can see here, stained positive, as well as their PCR also stained positive. And as we'll talk about, and I know this is hard for you to see, but really what I wanted to say is that you'll see it says see footnote, and the footnotes just really explain what they do. And as you can see, they were explaining that they use a rabbit polyclonal antibody that reacts to several mycobacterium, but also cross-reacts with other funguses, and it could also cross-react with Rhodococcus, nocardia. But actually, in addition, they'll also do PCR. And initially what they do is they look for a PCR first that just looks for mycobacterium and doesn't really speciate. But if it's positive, then they can speciate for you. And in this case, the speciation was specifically tuberculosis. But when I say TB, I mean TB complex, meaning it could be TB, bovis, or any of the other organisms, which we'll talk about, that make up the Mycobacterium tuberculosis complex. So with their diagnosis was left ovary biopsy marked diffuse granulomatous oophorytis with multinucleated giant cells of mineralization, rare bacilliform organisms observed on Phyte, meaning that it stained it was AFB, which is usually consists with a mycobacterium. And as you can see, the immunostaining was also positive mycobacterium, but the molecular evidence was specific for MTB. Great, fantastic. Answers question number one, confirms our diagnosis, but still doesn't answer the next questions, which is well, if this is TB, could she have multi-drug resistant TB? If so, would we treat her differently? How would we know? Or as importantly, or maybe not as important, but also important, is this bovis? And one of the ways to tell if this is bovis or not is that bovis is almost always resistant to PZA. And we can tell that. We can tell that by molecular drug resistances. And I think many of you are becoming more and more familiar with the ability not only by using PCR to be able to tell it's TB, but we now can tell if it's resistant to INH, rifampin, ethambutol, PZA, the injectables, the quinolones. We have the ability now to look for mutations to tell. So what's cool about the CDC pathology lab is once they get the DNA, they turn it over to the CDC's TB molecular lab where they actually can do MDDR testing. And I purposely are using the forms that they actually send you. I've obviously gotten rid of the patient, any identifiers. But notice on this, they actually took DNA, they multiplied it up, and as you can see, this was not consistent with multi-drug resistant. But initially, one of the problems they had was the PNCA, they couldn't amplify it. There wasn't enough DNA. They were able to go back in, they were able to amplify it, and interestingly enough, it did show a mutation, which was consistent with bovis. So this child was felt to have genital urinary TB due to Mycobacterium bovis. The sputum AFP cultures were negative. Interestingly enough, the mother's quantiferin was negative. She had a history of negative PPDs in the past. The patient's cyst was also negative by quantiferin. They're both healthy, asymptomatic. Interestingly enough, the uncle, the aunt, the father, they were all quantiferin positive. They were all born in Mexico, but they were asymptomatic. They were healthy, and all their chest x-rays were negative. And as we kept pressing and pressing and pressing, mother suddenly remembered something very interesting, was that the mom's mom, the grandmother, lived in Mexico. And she actually lives on a really nice farm, they said. And one of the things that the grandmother liked to do was send cheese. And she started sending cheese about a year to 2 years prior. But the family hated the cheese. They said they just didn't like it at all. It just wasn't to their liking, except the child, the patient, actually liked the cheese a lot, and she was the only one who ate it. So we believe that the child probably caught M. bovis from infected, unpasteurized milk, which we'll talk about. The good news is the child is tolerating her TB meds. Unfortunately, she couldn't swallow pills. She had an aversion, and the dosing was a little difficult. So we actually compounded the TB meds. She's doing well, and because this is bovis, because it is resistant to PZA, the patient's going to get 9 months of therapy with INH and rifampin. So what I'd like to do briefly now is kind of go over some of the different issues or different parts of the case. So just to start with, as you guys know, as we talked about, TB is the leading cause of death from any single infectious disease. In 2016, it was estimated that about 1.8 million people died of TB, like we said. Still in the United States, about 1,000 to 2,000 people die every year. About 1/3 of the world's population is estimated to be infected with TB. In the United States, about 4%. But that's overall. It depends where you live. Like in places like South Florida, where I live, it's closer to about 10% of our population is infected. Every year worldwide, there's about 9.5 million new cases of TB, about 9,400 in the United States. There's 11 to 14 million people walking around with active TB every day in the world, about 14,000 in the United States. And as you know, one of the things that's really concerning us more and more are multi-drug resistant strains that no longer are able to be effectively treated with INH and rifampin. And in the world now, about 15% of all new cases are MDR. Luckily, in the United States, we're still less than about 1%, but most of our MDR cases, at least in Florida, come from individuals who were born or lived in other countries. So when we talk about Mycobacterium tuberculosis, we talk about what is it caused by. And, as you know, Mycobacterium is mainly an airborne disease, as we'll talk about in this case, a little different. And it's caused by bacterium or Mycobacterium called Mycobacterium tuberculosis. It's actually part of a complex. There's actually a number of organisms that actually all look pretty much the same. They cause a disease that looks the same in humans, but they're slightly different from, from what parts of the world they come from, or what's the vector, what's the animal. So like M. microti, comes from mice. M. bovis comes from cows, as we'll talk about. M. mungi comes from mongooses in Africa. I don't know what your mongoose problem is up in Chicago. I don't think it's that big. Or M. pinnipedi actually comes from seals. But in the United States, by far the majority of TB cases are caused by Mycobacterium tuberculosis. And as you guys know, the organism is also called tubercle bacilli. One of the things I always like to talk about, and I think it's good to take a minute and just review how TB is spread. And as you know, the key to the spread of tuberculosis in most individuals is this cavity here, this hole in this person's lung. Inside that cavity is literally billions and billions of organisms of tuberculosis. That cavity is in communication with that guy's airway. So every time he sneezes, every time he sings, every time he speaks, he's putting TB in the air. But the key to the spread of TB is the cough. And why is it the cough? And that's why we always ask, are you coughing? Are you coughing? It's not only is it a symptom, but it's an effective way to transmit TB. And why is that? Because when you cough, anything that comes out of your mouth is traveling at the speed of a bullet. And what happens is that fluid that's coming out of your mouth, as it's coming out at that speed, the fluid evaporates, and you get left with airborne droplet nuclei. These are small particles of TB, anywhere from 1 to 5 microns large. And the importance of the size is anything less than 5 microns, once it gets in the air, will stay suspended in the air for minutes, hours, days, or weeks. And that's the key to TB. Once it's in the air, it will stay there. But here's the issue. If you're outside and you cough, the TB just gets dissipated and it just goes into up into the upper layers, and you don't catch it. And also ultraviolet light kills TB. But the key is, so how do you catch TB? So the way you catch TB is close contact, sharing the air in a poorly ventilated environment, like an indoor environment where there's no air. So once that TB gets into the air, it stays there. So the way you catch TB is close contact, sharing the air in a poorly ventilated environment, and then lastly, for a prolonged period of time, for at least 6 hours or more of direct contact. And why is that? Why does it take so long? And the reason is that studies show that even when somebody has active TB, even if their smears are positive, meaning they have a lot of organisms, you're only putting about 1 particle of TB into the air for every 10 to 12,000 cubic feet, meaning in a room like where you're sitting right now, there will be maybe 1 or 2 particles in the air, which means that in order to catch that TB, you have to be in that room long enough to breathe in enough air to breathe in the TB. So how do you catch TB? Close contact, sharing the air in a poorly ventilated environment for a prolonged period of time. And that's why it always gets me. I hear all the time, oh, TB is a highly contagious disease. It's a highly contagious disease. It's really not. As a matter of fact, only about 1/3 of people who actually live with somebody with TB or work with them actually become infected. Only 1/3. But interestingly enough, the average TB patient spreads their disease to 20 to 35 other individuals, which tells you that we spend a lot of time in these closed environments, you know. So how do you catch TB? Close contact, sharing the air in a poorly ventilated environment for a prolonged period of time. So what happens when you breathe in TB? And normally when you breathe in TB, it goes into your lungs. And when it goes into your lungs, you get a small patch pneumonia. But interestingly enough, this infiltrated pneumonia is so small that you don't see it on chest x-ray. For the first 6 to 12 weeks, interestingly enough, nothing happens. What's happening is it's sitting there, but what is happening is that your alveolar macrophages, these cells in your lungs, actually will engulf the TB and will try to take it back to the immune system. And the way it does that is it takes it back from the lungs through the lymphatics. And where does it go? The first place it goes is to the hilar lymph nodes. From the hilar lymph nodes, it goes into the mediastinal lymph nodes. From the mediastinal lymph nodes, they go into the thoracic duct. And as you guys know, the thoracic duct empties into the heart. And once TB is in the heart, for those first 6 to 12 weeks, TB is spread all over your body. You get it everywhere. But you're not sick. And why aren't you sick? Because there's so few organisms that your body's not reacting. But it can't kill the TB, but it's spreading. But finally, within 6 to 12 weeks, suddenly your immune system, particularly your T helper cells, and that's where the connection to AIDS comes in. It's your T helper cells that says, hey, that's TB. But again, they can't kill TB, but they surround it with a layer of fibrosis or scar tissue and then calcium. And this is what we call latent tuberculosis infection. By 6 to 12 weeks, your body's T cells now are able to surround it, build a wall around it, and keep it from growing. And that's what LTBI is. You have live organisms in your body, but your body's immune system is able to keep it in check, not allow it to grow. And that's what 1/3 of the world has. 1/3 of the world has TB in their body, but luckily the vast majority will not get sick. And why is that? Because in the vast majority of people throughout the world, their immune system will be strong enough to keep the TB in check. And interestingly enough, TB will live in your body for 60, 70, 80 years. But what happens to about 5 to 10% of people, specifically 5% of people within the first 2 years that they breathed in TB, and then another 5% for the rest of your life, what will happen is they'll develop some other immunosuppression, or they will not be able to contain the TB. And what will then happen is the TB will start to grow. It grows. It gets so big that the center necrosis, that's that caseation or cheese-like, or what they'll see under microscopy, which is necrotizing granulomas. What happens then, it eats its way into an airway, and you cough all this up, and you develop this cavity. And this person has active TB. This person is sick. This person's having fevers, chills, night sweats, weight loss, profound weight loss. That's why this disease used to be called consumption. People will lose 30, 40 pounds within a matter of weeks to months. I always joke, and it's no joke. If we could figure out what about tuberculosis makes you lose that much weight, and if we could put that in a pill, we would make Bill Gates look poor, right? That's the thing to do tonight when you leave, is figure that out. You become rich. But the bottom line is patients who have active disease, right, they're symptomatic. They've been sick for weeks or months. Their x-rays are abnormal, as we'll talk about. When I look at their sputum, I can see the tuberculosis, and they're contagious. This person has active disease. This person, latent tuberculosis, you're asymptomatic. Your chest x-ray is negative. All you have is a positive skin test or a quantiferin that tells you you've been infected, and you're not contagious. But what you have is the ability to go from infection to disease if something should happen to your immune system. Again, 5% of people within 2 years of becoming infected will go right from infection to disease, what we call progressive post-primary, and another 5% sometime in their life they'll develop diabetes or HIV or have to be on steroids or cancer or tumor necrosis factor blockers, something that will not allow their T cells anymore to contain the TB, and then they'll go from infection to disease. So like we said, what causes you to go from infection to disease? 5 to 10% of HIV negatives will progress from infectious disease, but I kind of lied there, because what I didn't tell you is 8% of patients who are HIV positive who are also infected with TB, 8% per year will go from infection to disease. Think about that. How long is the average patient with HIV now living? 15, 20, 25 years, maybe longer, hopefully longer. And that means that if you're infected with TB and you're not treated and your immune system stays weak, you are pretty much going to get TB. And not only are we seeing this with HIV, we're seeing with other things like tumor necrosis factor blockers and steroids, transplant patients, where we're seeing much higher rates of going from infectious disease. As we talked about, only about 25 to 30% of close contacts become infected, but the average TB patient infects 30 other individuals. What about M. bovis? Like in this case, M. bovis is interesting because it's not very common. The vast majority of cases, like we said, in the United States are caused by MTB. About 2% of U.S. cases are caused by M. bovis, and most of those people, when they went to look at it, have the risk factor of eating infected meat or cheese. Most bovis cases are extrapulmonary. As we talked about, the way you catch M. bovis usually is by eating or drinking contaminated or unpasteurized milk or dairy products. And as you know, pasteurization, the way it kills the organisms, they rapidly heat the milk and then cool it. You can also rarely get it in hunters or people working with cattle or bisons or deer. So people who are hunters, sometimes when they're skinning the meat, they can actually get it by either rarely breathing it in. It's usually not inhaled unless you're like shaking the meat. It's more like that it enters a wound in your hand. In the United States, M. bovis is pretty much under control thanks to pasteurization, and also we monitor all of our herds of cattle, and if we find one that's infected, they will destroy the herd. But the one thing that is important to know is that it is still very prevalent in Mexico. Matter of fact, in 2005, the USDA actually isolated M. bovis from cheese products that were being brought in from Mexico over the border. So this is still a way that you can get M. bovis. You know, when the way you usually get M. bovis is, as we said, you eat it. It usually goes into either your tonsils, and when you eat it or drink it, it will go through your tonsils into your lymph nodes and cause something called scrofula, that you'll see large lymph nodes in the neck, or it will actually get down to your GI tract and can cause a colitis. It usually involves the ileum and the cecal area, and the reason is that's where all of our lymphatics are. TB loves the lymphatics. I mean, because the immune system is trying to get it back, I mean, the immune cells are trying to get it back to the immune system, it will go through the lymphatics. And the most common place, or the area that has the most lymphatics, is the ileum and the cecum. And also that area is also an area where stool tends to stay around, or it'll go through what's called physiologic stasis. So there's more time for the TB to be absorbed. You know, the biggest problem we have with M. bovis right now and TB, because it's not only just bovis that causes GI TB, but if you have bad pulmonary TB and you keep coughing, and then you swallow the TB, you could also get TB of the GI tract. And the biggest issue we're having now is that a lot of patients, the disease looks just like Crohn's disease or ulcerative colitis. And as you've heard from TB now, you can't listen to TV without hearing TB on the TV. I don't know about you, but every time a tumor necrosis factor inhibitor commercial comes up, they always ask your doctor about what you need to do for TB, you know, and be tested. And the reason is, as we talked about, these tumor necrosis factor inhibitors, what they'll do is lower your immune system and cause you to go from infection to disease. So we're seeing more and more of that in patients who they thought had Crohn's disease. They treat them and then they get disseminated TB. So one of the things we always talk about is, before you do this, is test them for TB, and also think that if you have somebody from a part of the world where TB is prevalent, that you may want to make sure that that's truly Crohn's disease, and that they look at the tissue when they do the biopsies and make sure that it's AFB negative. In this case, this turned out the child had genital urinary TB, and again, this is the second most common form of extrapulmonary TB behind lymphatic. Usually it involves the kidneys, but the way it's thought to occur is usually, like we talked about, within those first 6 to 12 weeks that you breathe in TB and TB gets into the heart and goes throughout the body. You get TB throughout the body, including the kidneys. But interestingly enough, like in females who get ovarian involvement or uterine involvement, the other way you can do this is actually through sexual activity, though it's rare, and then most commonly lymphatic spread. Like in this child, if she had TB of the GI tract or the lymphatics and it spread down, though we had no evidence of that we could find, then that would also cause it to go into the pelvis. And I don't think we appreciate how serious and what kind of morbidity this has. But just to show you that in India, 18% of infertile women actually suffer from GUTB. And in India, it's one of the leading causes of infertility. So it really causes a lot of disease, and mostly it's usually the fallopian tubes, but it also could be the ovarian involvement. So how do you diagnose TB? And I think the key is think TB. When you have somebody who has epidemiologic risk factors, like they were foreign born, or they lived in a place where there's a high rate of TB, or in congregate living centers, or they're immunosuppressed, and they have symptoms, and this is the key, of long duration. TB is not an acute disease. TB is not something that you were, fine yesterday and today you're sick. TB, usually you've been sick for a long time, though in this child it is baffling. But usually it's often long duration, weeks to months, and they usually have other symptoms: fatigue, malaise, weight loss. And usually if it's pulmonary, they usually have a prolonged cough, they're coughing up blood. But in extrapulmonary, they usually have symptoms in this area. Like in her, she had what looked like appendicitis, and was. And the key is, not only do you need to, when you think TB, the key is you got to isolate the patient. And then once you isolate the patient, it's very, very important that you send for the appropriate mycobacterial studies. A lot of times, we're not thinking TB, we put it right into formalin, and then we can't do the cultures. I do want to remind everybody, just real briefly, that when we talk about isolate, I do want to remind everybody that the FDA and now the CDC is recommending, the FDA and now the National Tuberculosis Controls Association have put out recommendations that when we do isolate people, remember the PCR, the gene expert, may be very, very helpful in getting people out of isolation. And now many hospitals, especially here in Florida, we use 2 PCRs. If they're negative, we can take the person out of isolation as long as the clinician feels strongly that it's not there's not a strong chance that it's TB. In studies that we did here in Florida, we're finding that we can reduce getting people off of isolation from 5 days down to 2 days, and we're saving on average around $11,000 per patient put into isolation. So I just want to remind everybody, besides when we talk about diagnosis, for PCR, there's another role for PCR, which is airborne isolation. Classically, when you're trying to make the diagnosis, you do a chest x-ray first. You can see these upper lobe infiltrates and cavities, which are more significant. Which are usually suggestive, I should say, of TB. The next thing you do sputums. Normally we do AFB smears, and as you know, the AFB smear is relatively cheap and rapid, but the problem is only about 50% of patients who have active pulmonary TB will have a positive smear. And the other thing is that it's not also specific. About 30% of patients in Florida that have a positive smear will not have TB, but will have a non-tuberculous mycobacterium. So what do we do next? We then do a culture. The culture is about 80% active. Again, I want to emphasize, cultures are not 100% sensitive. There's about 20% of patients that have what we call clinical TB, meaning they look like TB, they have signs and symptoms of TB, their x-ray looks like TB, you put them on meds and they get better, even though their cultures are negative. That's culture negative or clinical TB. The problem with cultures is that it takes about 6 weeks on solid, about 3 weeks on liquid to be positive. And then if you want to know if they're sensitive or not, it takes another 1 to 2 weeks. And that's where nucleic amplification comes in. And that's why the CDC is now recommending that any person that you think has TB, at least one sputum should be sent for a PCR. And as you know, the results are now ready in about 2 hours, anywhere from 2 to 6. If the smears are positive, it's about 98% specific. That if it's smear positive, if it says it's TB, it's TB. And more importantly, if the smears are positive on 2 and the PCRs are negative, then you're pretty sure, about 99%, that this is not TB, it's an NTM. The only problem with PCR is that it's not 100% sensitive. It's pretty good on smear positives, but again, on smear positives, you're looking over 90%. On smear negatives, again, it's only about 60 to 80% sensitive. So if you still have somebody you think has TB, even if the PCR is a negative, you may want to start them on therapy while you're waiting for the cultures. One of the things we alluded to, and I want to emphasize, is that not only can the PCR now tell you if it's TB, but now we can tell if it's multi-drug resistant or not. And, you know, with the Gene Expert, which is the most common test being used right now, it tells you rifampin resistance only. And again, rifampin resistance is associated with MDR strains. In Florida, we use what's called the Heinz test, which not only tells us rifampin resistance, but also INH resistance. And now in Florida, we actually could do expanded molecular susceptibilities, like I said before, where we could actually tell you if it's resistant to ethambutol or PZA or the injectables or the quinolones. And thanks to a partnership between the Florida State Lab, the SNTC, and the CDC, if you ever need access to molecular drug testing in a patient that you feel you may have MDR, if you contact us, and again, with the approval of the state program, we'd be happy to run that for you if you need it. You know, I just want to briefly talk about pediatric TB and the issues you have. And as you know, most kids, you don't make the diagnosis bacteriologically. It's too hard to get sputum from them. And usually it's a clinical case based on a history of contact. You know, if they have a positive IGRA or a skin test, an abnormal x-ray. And again, you know, usually we don't get the cultures. Matter of fact, here's some statistics that show that most cases of TB in kids are usually found through a contact investigation or screening of high-risk groups, and only about 15 to 40% of active cases are found in kids who are actually symptomatic. So usually that's where the importance of what we do in our community around contact investigations becomes so huge. I also want to remind you, and I think you all know that, but it doesn't present with the classic upper lobe infiltrates or cavities, but usually lymphadenopathy. And again, why? Because like in a child here, here's the initial Gans complex where the child actually breathed in the TB or primary complex. Like we talked about, it then goes to the hilar lymph nodes, and from the hilar lymph nodes gets spread throughout the body. So this is primary TB. And on CAT scan, you can see this huge mass of lymph nodes in the right hilum. You know, what are the challenges of pediatric cases like we saw here? You know, they're harder to diagnose, and sometimes you really need pediatric consultants. And one of the things why I want to just emphasize here is that we are thrilled to be partnering with Illinois now. And if we can ever be of any assistance, you know, if you have a pediatric case and you need assistance, Anna Alvarez of our Southeast National TB Center is available for you. She's outstanding. You know, but the other issues you may have is, you know, some of the meds are difficult to give. Sometimes we have to compound them, and also the dosing is so hard. And in some of our kids, we're not so quite sure if the dosing is correct. And again, I want to offer this to you guys in the audience. If you have somebody who you think you need drug levels on, you have somebody who's either not responding or they're on other medications that interfere with the TB meds, or their weight is too great, they're morbidly obese, or on the other hand, they're kids, or you have somebody with renal disease or liver disease. If you need therapeutic drug monitoring, thanks to a grant through the Virginia TB Foundation with the SNTC, if it's felt appropriate, we can get those levels for you and actually support it for you. So again, if you have a case you think you need it, please give us a call. We'd really be happy to help out. So with all this, what's the good news about TB? The good news is in the rates right now of TB in the United States and the world are decreasing. We have better diagnostic tools, and we even have new therapeutic options. What's the bad news? The cases now can be very complex, especially when it comes to things like extrapulmonary and drug resistance. But really, I think one of the biggest issues we're having right now is with decreasing rates, there's less expertise in the community. More and more people are being surprised. And the problem comes down to is that if there's a surprise, if we're not thinking TB, if we wait too long to make the diagnosis, then TB is spreading. And not only that, but I think it's becoming more and more difficult to take care of complex cases because most physicians who've recently trained, they haven't had experience with TB. And that's why one of the things I think is very important is that if you have a really complex case that you think may benefit from consultation, or you need advanced resources like molecular resistance testing or PCR or therapeutic drug monitoring, if we can be of assistance, please call us. So in summary, think TB. We already talked about TB and M. bovis may present in extrapulmonary forms. It's hard to diagnose. You may need advanced diagnostics. M. bovis is still prevalent in resource-poor countries and may be acquired by oral route. Molecular diagnostics, including resistance testing, is available and may assist in cases where specimens for cultures were not obtained. Like in this one, I highly recommend it. You guys will see, I promise you, at least a number of cases every year where they thought it was cancer or they thought it was something else. We can still make the diagnosis. And then what I really like to emphasize is complex cases may benefit from consultation. And if you think we can help you, we have access to quote-unquote TB experts, and I use that extremely loosely when it comes at least to me. We have pediatricians, pharmacists, nurses, program consultants, and access to advanced resources. If you need them, we want to help you, So I can't tell you how excited we are to be able to be working with you. We are so excited to be your colleagues, and we want to thank you, especially on this World TB Day, for all you do. And please become a leader. Please become a shouter. Shout it from the mountaintops about TB so we can educate and what resources are available. And again, one of the things I want to say is we have a 24-hour, 7-day-a-week, 365-day-a-year hotline, 1-800-4TB-INFO. That's 1-800-4TB-INFO. We're here waiting. We'd love to speak with you. And I want to emphasize, speak with you. I really believe that the best consultations, the best education, the best training, the best interactions, the best collegial, spirit is to talk. And this way we can discuss the case, and we even can look at your X-rays if you want. We have the access to those kind of technology, so we can review it with you. Please give us a call if we can be of any assistance. We also have our website. It's a great place to start. If you want to hear about or what training, we have a great course that's in beautiful Florida, and I bet in Chicago around December it would be a really nice thought to come down to beautiful Florida and join us for a week-long TB course. We also have on our website the medical consultation. If you don't want to speak to us, you can email us, and we have a lot of resources and products for you. So please jump onto our website. And lastly, I really want to emphasize that we have to be the leaders. We have to be the advocates to make sure once and for all that we get TB eradicated. And with that, if you ever need us, please, if you want to speak to the main office, call 866-265, that's 7682, or SNTC, that's 866-265-7682. And then, like I said, please call us at 1-800-4TB-INFO. That's 1-800-4TB-INFO. 24 hours, 7 days a week. We want to talk to you. Or if you don't want to talk to us, please enter your consults via the web. With that, thank you so much. I'm going to actually hang around right now and answer any questions you may have or any comments about the case or issues, whatever you want to discuss. We're here for you. Chicago, thank you very, very much. Thank you for all you do.